Okay. Good morning, uh, uh, Jaspal, Arneja, and Vivek Maruti. You can hear us well and see us well.
Yes, sir, you're
Yes,
absolutely
sir.
audible and
Perfect, sir.
visible, sir.
Okay, we can and
Welcome.
we can see you both, and of course, every year we are part of your conference. Today you are our
Yes,
guest, guest faculty,
uh,
and clearly from
always a
Mount Sinai.
pleasure, sir.
Fantastic, my friend. And of course, our cath lab with Anu my side and the fellows on the right side and rest of the cath lab staff all are ready to show another case, which is a little change in the plan. And we'll ask, what would you do? Our two fellows are Ali and mine. We have 8 international fellows. One or two are from India. And actually, and then of course, purpose is that they go back and advance the field further. So with that note, let me just start our case because this will be may require some timing because of the issues with the calcification. And this is the Mediquest supporting, and of course Jaspal and Vivek, individual description. Both, particularly Jaspal, very well known interventional cardiologist, senior and the chief and the director of the cath lab, Arneja Heart Institute, Nagpur. There's a lot of live meetings and very expert interventionalist, both coronary as well as structural. Done first TAVI in central India and so. And Vivek Maruti, as I said, up the budding interventionalist, very good interventional skills, has participated in numerous complex interventions and the live relays, and hopefully will get all the our input and our audience of the Mediquest live. So with that note, this is our goal. Then we'll have a case safety measures of rotational atherectomy, case-based discussion after this first case. So this is the live case 28 with Mediquest, a 61-year-old female who has class 3 angina and positive stress test, has multiple risk factors shown on the left side, but already had taken toll in terms of the insulin requiring diabetes. Hemoglobin A1C is still about 8.6, and the rest of things shown there. A patient had a okay EF in the past, had a cath many years ago with a calcific 2 vessel. That time, cabbage was recommended but declined. And patient is on good medical therapy, and then was presented to us with on January 30th with calcific 2 vessel disease of the LED diagonal bifurcation and circ. So I taken care of the LED. Everything was 111 with a good EF, and today is for bifurcation circumflex branches. We put a orbital atherectomy, and we'll ask. I know the orbital is being used there now, and I know Jaspal you have used some. So what will be the little change in plan from our point of view, and Anu will show the case here. So this is the
So EF is normal, EDP was 22. So right coronary artery, severe diffuse disease, again same calcified as well as torches. I think in cases like this, medical therapy is not, probably a good option for this small vessel. So this is the left system. Left vein is normal. Had a prior stents which looks okay.
Now, can we show the LED diagonal? We have the picture here. I did a mini crush about yeah, beautiful.
Yeah. So now
Yeah,
today
very
plan is to take care of this circ bifurcation. So now before we go there, I want to show. Did you have the caudal picture? Oh, we don't have LA caudal, right? We don't have. So in LA caudal, actually, you could see this is a retroflex, a circumflex. There's a OM1 disease, distal circ has a disease, and then there is a OM2, and then there's LPL. So I think the disease in the distal circ goes all the way up to the LPL. So bifurcation essentially is from prox circ to OM1 and then the entire distal circ. Calcium, you can see, at least moderate angiographically, likely more than that. So we try to do intravascular.
Keep playing. No, I think that's a very important point. At the bifurcation, see, it looks like there is a calcific nodule sitting there at the bifurcation. And the question are two, and I know we just came back from the India Live. There was a lot of discussion about imaging. So Jaspal, based on this, if you had to do image, preference, IVUS or OCT, one versus the other, what will be the choice?
No, as far as this, if you want to see the calcium, the thickness of the calcium, I think OCT would be a better option. But it will give us the thickness and the length. So obviously, but then, getting a catheter down here would
Yeah.
be difficult before you actually modify the plaque. So that's going to be a challenge. So I think the calcium appears quite significant, and upfront some atherectomy has to be done in this patient. I don't think without that you would be able to get a catheter down, either an IVUS or an OCT catheter down into these coronaries.
Fantastic. So this is what exactly we knew that, and that is what we do in real life. But I know everybody is imaging fanatic. I said let's show it. So Anu, tell us what you did.
No, this is we use fielder, which is polymer jacketed hydrophilic coated wire. If you see, just wanted to see how the circ is going. This is the proximal circ, all very tortuous.
Yeah.
Yeah.
Very it's a
Yeah,
retroflex.
and then was not
Yeah.
easy. Yeah. Then we were able to wire we use a fine cross. With a fine cross, we came all the way to the proximal circ, move around the wire a little bit. Then we are able to, you can see us get into the distal circ.
Yeah.
So we're going to OM2, reorient it, went into the LPL. So then we changed it to rota wire, and this is the IVUS, like you mentioned, not able to, it's a short monorail. So when you have calcium and this kind of tortuosity, many times these imaging catheters don't go, we're not able to advance. So this was IVUS, we tried to do it and not able to go because of the short monorail. We just stopped it there. Having faced all that, one tortuosity in the circumflex, we have downgraded the burr, also changed from orbital atherectomy to 1.25 rotational atherectomy.
So two changes as you predicted. Now question is very clear for the audience. Once you have this kind of retroflex complex lesion, I would say don't even try the, as you said, the imaging before you do modify the plaque. So this is just wanted to show it. Second, well, tortuosity clearly is with a rotational atherectomy versus orbital, both are tough, both are difficult, but I think orbital will cause more wire bias because of the wire being 0.012 inch compared to a rotational atherectomy, which is 0.009. So initially, although we announced it that we'll do orbital, but after looking at the case, Anu had decided that we should go with the rotational atherectomy, because in real life, this case we will do with a rotational atherectomy. We had done orbital in the past, and we used to see the gutter created by that. Jaspal, how has been your experience with the orbital so far?
Sir, orbital has just come into the country, and
Yeah.
we are yet to use orbital atherectomy
Okay.
at our center. So I have not really used orbital atherectomy, sir. So I really don't have
Let me-
experience about orbital.
Okay, good.
So this is the type of case I would say with the tortuosity. If you have a choice, we are definitely, this is the case where which atherectomy would you use, and this is the case I would say do not use orbital because of this much tortuosity, because that is going to create a wire bias and clear cut the gutter because of the tortuosity, and because it's simple.
Right.
The wire is a 0.012 versus 0.009, and hopefully it will
9.
take the shape. Yeah.
No, is that the reason, or is it also in rotational atherectomy? You have to remember what is a conical shape, and all the diamond chips are in the front, so you are able to navigate the burr easily compared to your orbital
Get the balloons.
atherectomy. The crown is a little bit behind.
Yep.
Yeah.
Beautiful. Okay.
Okay,
So
we are doing our 3 steps here. Move the knob backward forward, if you can see it.
Yeah.
All the tension between the Teflon sheath and the bar is gone. Then at the
Yeah.
Y connector, backward forward, any of the tension between the bar and the wire will be gone. So then we will do a short dyna tap. Good. So ready?
Yep.
Again, this
second.
was a retroflex circumflex and lot of tortuosity. Again, whatever atherectomy we use, I think we have to be extremely careful at these bends.
Absolutely. This is the, I would say, full substrate for perforation.
Yes, absolutely. And I think since you are going so distal, sizing the bird to 1.25 is absolutely the right decision.
Good. Come on.
One more. I want to do one more.
Okay. Yeah, absolutely. 1.25. So there was a lot of question when Anu did the live case of that where if you have a large vessel, where do you size the bar of 0.4, 0.5 has to be to the distal vessel. So this is the based on that it will be 1.25 bar. Yeah.
Would you now exchange the wire and burn into the OM as well, or you are done with the burn?
Good question. So I think what we do, so our idea is this wire will require recrossing. So we thought that this will be the time. Now we can put a run through wire into the OM and do the imaging. I mean, to me, looks like there is no calcium, or I would no calcium. I basically mean less than 2 quadrant calcium in OM1. But since we have the IVAS ready, we'll prove one versus other. We are ready with this burr. If necessary, we'll go into that OM1 also.
So, going back to the angio, I think the other thing also, OM1 if you need, if you see there.
Yeah, there may be a calcium also, very high. Actually, more, here become a little more prominent now. And the ostium big. Yeah. I think let's do there also. Let's see the picture. If it is, then we put a rotawire in OM1. Yeah. Let's take a picture.
No, other thing is that I think 125 bar will be okay. I was thinking maybe we have to change to 1.5.
No, 1.25.
But I think 1.25 will be okay.
Yeah, very good.
Okay.
You want to put this wire if it goes? Okay, that's the
yeah, I think there is a calcium, as you can see at the ostium.
I can see it, absolutely, fully agree. Yep.
Yeah.
Yeah. We'll get ready our fielder fine cross in case we does not go. Usually the rotawire making that angle is tough, particularly I would say now the rotor drive is also available in India. With the regular rotor old one you would not even think about, because that will not make even turn, but rotor drive might make a turn. Let's go to other view.
You find that advantage with the Viper wire in orbital atherectomy. The wire is 1:1 torque, and possibly so the rotor drive also sort of is now competing with the Viper wire as far as the crossing and maneuverability is concerned.
Yeah, so definitely the Viper wire, I think we had to go with this. So don't even go, because this is even this one we expect it will not be the key issue.
Give the fine cross here.
So key is that the Viper is a little better, but if you take at Sinai with all the complexity, as I said that we do about 75 atherectomies per month. Of them 60 are the rota, 12 is orbital, and 3 are laser. And laser cases are unexpanded stent, or if you could not cross. So that is roughly the distribution. And of these, if you take those, so basically those 75, I would say 80% of the time we go with a fielder fine cross. We think it's the easiest way, quick change. And so now I know, or a balloon, simple balloon, over the wire balloon, because to me, these wires are not our friendly wires. And when do we use these cases? We use in the complex cases anyway. So since we use that in the complex cases, so it always gives a trouble. You take time, give little die. So why do so? So I would just, therefore, the primary wiring versus the wiring with the workhorse wire, I suggest that unless it's a straightforward proximal RCA or proximal mid LED, should always use this combination. Yeah. And then maybe we can ask Vivek, in your experience, when you do atherectomy, what is your direct wiring versus over the wire and then exchange?
I think when tortuous segment is there, definitely, sir, over the microcatheter we put the wire, because damaging the stainless steel wire is very dangerous. If we somewhere it bends, it is very dangerous.
Yeah.
I think always better to go with the microcatheter.
Beautiful. Now, second question is, people always ask, and I know some papers have been written, now you are worried about the distal circ, because you cannot protect. The only advantage is that with the IVL, you can protect by putting a wire, but if you do orbital or rotational, you cannot protect the side branch. Now, people have done it, but not exactly in this case, because they have done it if the bifurcation is a little further. But since bifurcation is just at the 111, using a bigger guide and using the guide liner and exclude that wire,
Right.
get the burn differently, which will not be possible in this case because lesion starts right there. So that will not be the
Right.
answer in this one.
So, as we know in atherectomy, rotational,
Yeah.
dissections are very uncommon.
Yeah.
So, we should not really worry too much about losing the side branch when we are burying the other,
Who's-
even if there is lesion at the ostium of both the vessels. We usually do not get any, dissections
Yeah.
with rotablation.
Like in this case, see that? Yeah.
Fielder and run through ready again.
Yeah, see this now. Actually, this and also say many times the wire bias is our friend. Look at
Correct.
the lumen at the distal circ opened up with a 1.25 bar. It at least
Absolutely.
2.5 plus, double the vessels because it's basically cut in the inside area and the vessel has expanded. And of course, now we are ready with that calcium. Initially, I was not convinced, but in the alveocaudal view, we saw a lot of calcium and go on. Now, other point which we used to worry about, check the speed of the device outside and so with the Rota Pro, I'm telling everyone, don't waste time. As you know, I work with a company, it comes set at 155. You don't need to test outside. 100%. So every time it will be 155 start. You want to go lower or higher is a different story once you are in. But otherwise, there's no need to regular check the speed outside because that has become very clear cut now. Yeah, good. Polish.
So did you face resistance as you went in initially?
Sorry?
You did resistance.
Did you face
No.
resistance?
The resistance I think is because of the angle.
Yeah.
Okay.
Not because of, yeah. No.
And Vivek, if any
lot
question.
of people always have issues. They think 1.25 bar get stuck a lot. They think 1.5 bar is better than 1.25. That's not our experience. And, with these complex cases, doing 1.25 bar, the way we have shown, just be very meticulous, remove all the tension and the slow burring. This is the best bar size actually.
Actually, our concept now is just modifying the plaque rather than debulking. So I think 1.25 bar in most cases, or maybe 1.25 or 1.5 is usually more than enough.
That's it.
No,
and you see that
we don't want.
Yeah,
it looks much better. Yes.
And
definitely.
no dissection, as you said, 1.25, 1.5 is completely fine. And even if basically say, well, it didn't do anything to the lumen, doesn't matter. It has caused the eccentric cut. And Kiski and with the IVAS will show that what the rotablation has done. It has just cut that circular lumen of your calcific vessel, so that subsequent vessel will expand with balloon dilatation and so. So now, which wire you are putting now?
This is a run through.
Okay, run through is going into the OM. Good.
And that give me a fielder for the.
Take the rota wire out now. Now, we also have said that if you use a very small burr and highly calcific vessel and large lumen, it's okay to leave the wire and then do a balloon in case it does not open, then you go to the bigger burr. So that I would say was the statement and advice 1.5 years ago. Now I would say that of course there is a cost constraint in India, but here,
New fielder.
yeah, in here now, the second burr is almost very, very rare. So used to be in the past, the 2-burr approach was about 8% of our complex cases, 8 to 10. Now it's like 1% only.
Okay, I think.
Because then we combine with IVL. I know the cost constraint there. Yeah.
So Dr. Sanjay want to know that after every rota run, you not take any check shot just to see flow?
Well, I mean, we will do it once you have set the wire, because yes, you'll do it. But EKG is good. You guys continue to show the hemodynamics and ECG. So if there is no ECG changes and we know that it's okay, because also you will see that even if patients' creatinine in this particular case was normal with a normal GFR, they always come back with some trouble. So we try to limit the dye. We are not the dye-less PCI. We are not a believer of that. But we say a small amount of dye. And I can tell you that I can, in one of the live case, I did the entire case without dye till end, first and end, making so landmark and even rotablation and so in the cases. So key is a small amount of dye is needed now since we have wire both. I think this is the case. If you want, we can just do the imaging, and really you don't need to see any, because hemodynamically yes, but patient has some EKG changes, some chest pain, some ST depression, then you definitely want to see.
Correct.
So we're going with the IVUS. Let's see if it will make a turn now.
Which branch?
from the
Which one you are
upper
going?
branch. I'm going the upper branch.
OM1.
Let's try to do one.
Yeah.
Now, I think it will be good to see if it has made cuts. But even if it has not, I'm sure it has weakened the calcium, and our balloons can do the remaining job.
That's it.
You see that? Even here, I'm having a problem.
Yes.
So now question is, will OCT go?
No. Okay.
No,
Good try,
unlikely,
because
sir.
there's
Because
Yeah.
Okay,
I think we should not try also, sir.
can you see something?
Yeah,
Show
no,
the
this
IVUS?
is a guided.
Oh,
This is
in
a
the
left
guide,
wing.
yeah, okay,
just
fine.
up ostial left wing.
No, pull the wire while you are advancing a little bit. So just do, because remember what happened is the small monorail. I'll pull when you are advancing. Let me have this wire.
No,
You have the run through?
It's an
Yeah.
angle.
Yeah.
So there is
Just
no
one second.
wire to it. There is no wire wrap.
No,
You know?
no, we don't have it.
Yeah.
Okay, come
Yeah.
closer.
And once you are ready, I'm going to pull back the wire when you are sending. Yeah. Yeah. Even then, see that? Nope.
Right.
See, with the monorail goes that angle, it goes into the LED.
Okay, you know what?
It goes
I will
into the
try on
LED. Yes.
Yeah. So let's go to the main circ.
I will try.
Yeah. Let's go to the distal circ because that's a floppy wire. Maybe that will help. Let's go. So we have the fielder wire, regular fielder in the distal circumflex, and we are going to do the IVUS on that.
Okay.
This is also a teaching point. I think at this time we should just do balloon and take care of the lesion rather than get gung ho
Yes,
with this imaging.
Yeah.
Yeah, exactly. If this doesn't go, I think we should just take balloon and
we
try
are ready
to-
with them.
Take care of that, exactly. And then you maybe the final optimization.
Yeah, we can always
do. Take care.
we can always do. Correct. There we see.
Yeah, good. Yep. Okay,
I
good.
don't get it.
Okay, let's get our
So,
balloon at
fine.
2.520 in the main vessel. Let's do there first.
Okay.
I think this is an important point. Although we always want imaging in calcium, but most of the time, many times it is not feasible. At least to plan the strategy. If you have severe calcification, small lumens, no imaging catheter would actually go.
Distal circ.
Yeah. Distal circ, we are doing it now.
I think
And
also, sir,
and we encourage our audience also to ask questions and so. Yep. So now we are going with a 2.520 non-compliant balloon, which should make a turn. Although it may have tough time too.
Right. That may also have some tough time. Exactly.
Yeah. Okay. I think went in.
So
That's
that's
okay. Let's open it up here.
Yeah. Okay, go up here.
Yeah. So once your nose is in the lesion, that's okay to go few atmosphere and
Right.
yeah, go.
Again, circumflex are the most difficult to cross. It is a retroflex circ.
Yeah.
So
Go. 20.
the balloon seems to have
Down.
opened up.
Yeah. Now it
fairly
opened
well
nicely.
at the calcific
Yes.
segment. It's
Yeah.
opened very nice, very well.
Okay, go up here now. 20, 22. Yeah. Good. Down.
Now, if your balloon opens at 12 or 15 here, you would
Yeah.
still like to go to 2022 after rotablation?
Yeah, I mean, we have to make sure, yeah, good, because one, it's a large circumflex, okay? Now, is it
It is.
2.5, 2.75? So,
Yeah, I think the question is very important. Based on what the balloon size is. If you have 2 or 2.25 balloon, I think you can go to high pressure. We use a 2.75 or 3.0, we'll go to a lower pressure. The idea there should be a full expansion. Now this is the
full
case now.
expansion.
Yeah.
okay, go up here.
And
I
once
think
you're
that's-
ready and
Maybe-
try to see back and forth, because the stent has to come there. And then we take a picture now.
Good.
And maybe, check it into orthogonal views, whether the balloon has opened up completely or not. Since it's a, it's a lot of a teaching thing, although we know it is opened up well, but
Yeah.
especially in calcium,
Good. Go
there
up here.
could be
Yeah.
eccentric opening,
Absolutely.
and seeing into orthogonal views might be
Yep.
always
Yep.
a good thing. Yeah, it is all seems to open
Synergy
up
now.
very well.
It looks
Excellent.
good.
Yeah, excellent.
So you want a different one?
Same,
to
yeah.
the-
Score flex. You know what we thought? Let's see if we can get the score flex in that OM. Score flex is like a angiosculpt. With
Yeah.
the wire, one wire they use off the our patient vessel wire. One wire is outside the balloon, and we try to use it. If not, we use the same 2.5 balloon going into the OM. So we just want to
Okay.
test few things. Yeah. And this is score flex is 10 millimeter. In our lab, we keep Wolverine only 6 millimeter. So we, same that of course Wolverine is 6, 10, and 15, but we keep only 6. And score flex is
Okay.
10 millimeter we carry. And I personally think it will not go, but I'll be very happy to see if it goes.
Sir,
Okay.
how you choose in between Wolverine versus score flex in
Yeah,
particular
no, but
cases?
I'm very simple. I think this pure osteal lesion is a Wolverine or ISRs, and so particularly osteal lesion, short osteal lesion went very well. Good.
So so I think
yeah,
went very well. Yeah.
yeah.
Go.
And the cost is slightly different. Our Wolverine is about $100 more than the score flex and angiosculpt.
Okay.
I think it's about the little different there also, right? The cost is slightly different in India also.
Yeah, marginally different.
Marginally, yeah, it's about $100
Yeah.
difference here, $75. You have to go
So
to
I think
Austin little more.
I think another advantage of angiosculpt is it's now on a semi-compliant balloon. So maybe
Yeah.
if you have two different vessels, you can blow it up 2.5
Yeah.
to up to 1820. It
Cross.
goes up to 3.
Take a picture now.
So
Yep. So let's see if it crossed.
48.
I think it may not have crossed.
It did.
One second.
no, it did cross and it opened up
did,
well
it
as
did.
well.
Crossed. Okay, cross. Yeah. Okay. Yeah. Oh yes. I think go a little more, but otherwise looks good. 38, not 48. They're not there. Yeah. Go to see if we can go a little more into the OM.
Yeah.
We can go to a little high pressure now. There's still a lot of
No,
plaque
we
left.
did. We did.
No, this one we can go 24 now. Just like angiosculpt and score flex,
Yeah.
also you can go 24.
Right.
Okay, good. Down.
Yeah, it's opened up very well.
Very well. Yeah.
The problem is.
Okay, let's
here
decide
you
about
have
the
to decide,
stent
because
strategy.
You have
Yeah.
to come up till here. Go up
Yeah.
here. Because it has created a gutter in the proximal circ. We have to stent there.
Right.
Question is,
So, like-
the three stent means two in the distal circ, LPL, and one in that OM, knowing that we do not have a drug-coated balloon here yet. So we will
Right.
start having a
Okay.
drug-coated balloon. I think this is a good case for very distal LPL, do a drug-coated balloon, put a stent otherwise with a mini crush. But knowing that we don't have it, so we'll want to hear from both of you, Vivek and Jaspal, how would you take care of this now? Long lesion of the distal circ. You see that LPL already first or OM2 start having a low flow. I think we should to save it now. This is after the balloon dilatation. Otherwise, this will close completely.
No.
Unless you give some nitroglycerin and see.
Right now you have to stent.
Okay.
I think we need to
Dissected the
stent
vessel
this
so
area
badly.
because
That's-
lot of-
We have to stent it
Yeah.
first. Let's stabilize that, at least the main vessel.
Okay.
And then we work on
So
it.
you just short one then, right?
38?
2.75, 28?
28? No.
Yeah.
Yeah. So
You
just,
think 38 will be too long? and
yeah,
not
yeah,
go?
two may not go. No, but you
Yeah,
need two
yeah.
stents there anyway. So
No, no,
28 is fine.
because-
2.75, 28. See that?
Yeah.
2.75, 28. If that can goes good.
No, 2.5, no?
Okay, 2.5. 2.5, 28.
But
Yeah.
Hold on.
So I think 20 is a good choice. So
Yeah.
we didn't just still do distal dissection, so
Yeah,
that it doesn't
that's
extend further.
Yeah.
And I think we'll be a little careful in giving injections as well, so that we don't
Yeah.
get its dissection down further. So you're talking about drug-eluting balloons. I'm sure we are using a fair amount of drug-eluting balloons. In vessels which are smaller in size. The lesions are diffuse, and and we have got really good results. We have a follow-up of. We are also doing a follow-up of these patients after 6 months to 1 year check angios. They seem to be doing very well. The vessels grow up. We see a lot of positive remodeling also sometimes, after a drug-eluting balloon, which is not seen after stents. So, I think drug-eluting balloon is a very good option in diffuse disease rather than having long metals, especially in India.
Fully agree. And particularly the data supported recent paper from Korea, the small vessel DES versus drug-coated balloon,
Right,
quite
right.
positive in the small basket trial, and diabetics did better. So I think that's a good strategy. Fully agree.
Yeah, absolutely.
And
Again, strategy of
yeah, so what happened
again,
is in United States, the strategy now is the 3 drug-coated balloon trials will be starting in next, or one already started,
Okay.
2 will be starting in next few weeks. We are part of it with a sirolimus
Okay.
and 2 paclitaxel coating. Now, what FDA mandated, all 3 companies, they have to start with the ISR first. Enroll
Okay.
patients in the ISR. Once you are completed, then you go to small vessel, bifurcations, and native vessels. So they want to do ISR first and then go to the other vessels. So we will start with the ISR limb, and it's a the solution DES, which is the sirolimus. Ron Waxman is the PI with Roxana Meran, and we'll be starting part of it next month. Once they finish, likely that 300 cases need to be done. I'm sure they'll be done by September, October. Then we go to the
Right.
bifurcation and those small vessels, and so.
Okay.
Okay,
So,
good.
in these ISR,
Done.
what is going to be the pre-treatment? Are you going to, use just cutting balloons or laser that you also have? Or is there any protocol in this or
Yeah, so
whatever?
yeah, protocol basically they're saying that don't use rotational atherectomy, but cutting
Okay.
balloon, and I had to find out over the laser. They did say that rotational atherectomy is not recommended, but
Right.
but
The
laser
vessel is back
probably I had to
because the
find out over the
dissection
laser.
flap
But
was
cutting balloon,
covered.
yes, yeah, that is allowed.
Somebody said hi.
Go.
So the vessel is back. Dissection flap was
Yeah.
probably
Causing the OM,
Yeah.
that OM
slow
good
flow.
flow.
So
Yeah,
that's why there's a very important teaching point that okay, the
Yes,
side
ex-
branch vessel was going becoming Timmy 2 and all that, but we got to focus on the main vessel. So stabilize the main vessel, and then if the vessel still goes down, then only you go back to the side branch here. So we have done that. Now I think we can do
Absolutely.
bifurcation,
yep,
right?
yeah. Now we're ready for bifurcation.
So I think we can
So
take a
what-
18, 275, 18 to the distal circ,
Yep,
right?
Huh.
And then what, 30 to the upper branch?
yep.
so you're
3028
doing a you're doing
Mini
a
mini
mini
crush,
crush.
mini crush, yeah, mini crush, yes.
So you're
18 maybe
crushing.
plus minus go.
Yeah, so question is, we are thinking the distal circ as a side branch and OM as the main branch, because in case we have to go back in, which we had to go for the kissing balloon, will be easier, straightforward, rather than having an angulated vessel.
Okay.
18 you
Sounds. I
think we'll
think
cover
that.
it?
Yeah.
Okay, 18. 275.
Two-
And 30, what, 28?
28, won't go more than that. Now see that if you see that what is created
Not 28.
at the angle, at the proximal angle of the circ, like not extravagation, but just like vessel has opened up, which is okay.
Yes.
Because our wire and all these angulated vessels, wire is going into the gutter, but we are going to stand that
Right.
anyway. So it's not an issue
We are
right
going
there.
to step- Right. Yeah, I think.
Good. Let's go. So clearly
This-
is
this
that as
was
long
a-
as wire doesn't come back.
Exactly.
This is 28 may not cover.
I think, sir, that
Yes, yes.
hemodynamic monitor coming in distal vessels. So people want to review that, sir, if possible.
Huh?
18.
That hemodynamic monitor coming on the distal
Oh,
circ.
yeah, guys, move the hemodynamics onto the left side.
On the top.
Not top, left lower. Left lower is okay. Yeah,
Yeah, that's
good.
perfect.
That's perfect, yeah.
I don't see the hand movements.
Okay.
Please.
We are still
want to go
seeing
to
the
other view?
hand movements.
Yeah,
Yeah, that's it.
they're saying they're still seeing the hand movement. That's what we're saying, that
Yeah,
we're
we are
still seeing the hand
seeing the hand
movement.
movements.
Yeah, right there. Good. No, bring it to the same. Yeah, good. Yeah, good. Very good. Good. Okay. Good. The most important
Sameer?
is it's the OM. Yeah.
Give.
You're not a
Yeah.
great believer of DK crush.
Yeah, we actually, you know what, same. I know just because the steps, and I've, the many time, I would say debated DK crush versus mini crush. We are not a fan of cool out either. and tap
Right.
sometimes tap as a bailout, but not as a primary strategy. So we are
Okay.
same, with the bifurcation talk of the side branch when I said
We can show
the
mini crush
yeah,
side by
guys show
side.
the Mediquest app, but key is that we believe whichever way it is. I know in India, DK Crush is on the top. Everybody loves it, which is okay, nothing wrong in that. But my issue with that is that it has a multiple steps, which I think safely can be decreased by the mini crush technique. That's it.
Yeah. I think for an
Yeah.
expert, for an experienced operator like you, sir, the main problem with advantage of DK Crush is you're always able to finish with a kissing balloon,
Yeah.
But experienced, people like you would always, finish a mini crush also with a kissing balloon.
Kissing balloon, yeah. Go.
Some die.
So you see
we
that,
can't go the second strand. We don't want to, right?
yeah,
SS?
which is
Let's
fine.
just do it. Okay, go up.
Stepwise crush
Yeah.
we can do. Go.
You don't have a
Now
balloon,
get us a trio.
Yeah. No, but now we have to balloon there. You have to have a balloon there.
That's okay. That's okay.
We have same
will
balloon.
Take it out.
We can use the same balloon and crush with that.
Whatever we had.
But unless you think it will go, no. Let's see if this goes now. Alone will not
We'll
go.
go it.
Yeah. Get the balloon, guys. Our earlier
That
balloon.
trio may not go SS.
That's
No,
okay.
whatever we had 2.75, 2.5. 2.5 balloon will be
No,
okay.
we didn't we go with the trio to the main
No.
with the cutter, right?
Yeah. The 2.5 balloon is okay. Good.
You know what? Not 2.5. It's a 20 balloon. Will not make a turn.
So 3 or 15.
Huh? Get us a 3 or 12 high pressure.
So you
On this
put a
out,
stent in the
Yeah.
in
In the distal circ. Yeah. Just at the ostium, we have done, and now we try to do the crush. So it's basically stepwise crush. So rather than a regular crush where both stents are there, here we have a trouble getting the stent in the OM after putting a stent in the distal circ. So therefore, rather than taking both of them out, let's put into the distal circ. We go back and crush it, and then go back with the stent in the main vessel to OM1, and then to, of course, do the final kissing. So it's a kind of a step crush
But then
technique.
you would normally would like to have a balloon in the
Yeah, I know.
OM1 to crush this
Yeah,
main vessel stent.
that is true, because now there may be a little difficulty in going in,
Yeah,
because what
now it
happened?
will be- yes.
Yeah, that is true.
We had difficulty even before.
Yeah, I know.
Yeah,
Even difficulty
but then
was there
you-
before. Now will be more difficult.
Okay,
But
got it.
let's open. Okay, good.
Yeah.
But
yeah,
now
got it.
the side branch wire has to come out. Very important. Okay.
Yeah.
When you're crushing, this wire has to come out.
Good.
Okay, go up.
Need to go a little more.
Yeah, I will. But I
Okay,
want to
good.
make sure that level it is gone.
Yeah.
Good. Down.
Yeah,
Yeah, it's
you can-
actually OM was very calcified also. More and more it is looking even more calcium than distal circ.
Right.
Means we needed a 1 fiber.
Yeah.
Down.
So I would just tell the younger cardiologists who are watching that
Yeah.
it is always a good idea for them when you're doing this to have a balloon to crush already placed when you are
Done.
inflating the stent, and you get the stent balloon and the wire out, and so that you can crush the stent.
Absolutely, no question about it. We did a little, I would say, variation from the technique, but for everyone from teaching point of view, as Dr. Jaspal Arneja pointing out to all our audience, you have to have in this the stepwise crush technique that your balloon has to be there, because sometimes otherwise it will become so difficult. Use a 1.0,
Correct.
2.0, 2.5. If your
Yes,
balloon
yes.
there will
What do you
cross
think?
directly there. Yep.
Yes.
So very, very
Down.
important point. Absolutely important point. Good. It's still trouble, huh?
Not able
Well,
to-
now you can use the guide liner if need to
Okay.
be. Yeah.
Yeah.
We can.
Because now you have taken the other wire out, and we can use the Godzilla or guide liner.
Okay, down. Okay, let's try with all this.
Yeah. Good. Okay. All right. So we are going to try.
You want to take a
What
picture
stent
so
are
we
you?
can see?
Did you take, or what?
Yeah,
stent
we
are you
have we
taking
had
for
a
this?
3028. We had 3028. That's what
Giants.
we use. Zions 3028. Yeah.
Okay, the Sky Point.
Yeah. The Sky Point. Yeah. Which should be better. And I know that in India there is still
This carbon is yet to come. Yeah, we still
Yet
don't
to
have
come.
it.
Yep. Okay. So let's try this. Otherwise, we'll use a guideliner. Good. Let's go.
I think, we're
Yeah.
discussing, as you said, TAP, and you're not a great fan of TAP and culotte. Basically, doing a mini crush really is the most secure way of always protecting your side branch.
Yep. Yep.
So,
Absolutely.
it's very predictable. You crush it and then you recross and finish the procedure. You're always, the side branch will never go. You're always have it under control.
That is correct. Yeah, except that, as you mentioned, that sometimes in a mini crush, although we don't have that trouble, but for many times maybe a trouble to get the final kissing balloon. So DK
Right.
crush allows it because you open up the side branch before, so
Twice,
that
yes.
we guaranteed it will go with the DK crush, that kissing balloon technique. Yeah.
Yeah.
Oh, good. It went in. You want to go to other view?
No.
That if you have, yeah. Take a deep breath. The deep breath helps sometimes. Now you have second wire.
Yes.
If you want to put the second wire, use it as a buddy. Breathe normally. Breathe normally. Yeah. Good.
Maybe it is the again, we have, when have difficulty here. Although here it is the angulation, but
Yeah.
sometimes inadequate crushing of that stent could also prevent the stent from crossing.
No, and that is why carefully Anu has dilated multiple times, went with that balloon
Multiple
3 or
times
12
at high-
and 20
yeah.
atmosphere. Yeah, 20 atmosphere.
I think I'm
They
sure
put a
it is
second
well
wire.
crushed.
Yeah.
But
Take a deep breath.
just
here.
as a
Get the
What
Godzilla.
is this angle?
Angle.
Yeah.
is the angle.
that's fine.
Yes.
Yeah.
And the calcium. Even
Yeah,
the balloon,
everything.
we had trouble in the beginning. You see
Right.
that, and
Yeah.
then we went.
Yes.
Okay.
Yes. Yes.
Use the
Also,
Godzilla.
what I
Yeah.
feel, I mean, I
No,
want
put
to
a second
see.
wire right now before you go. Here.
No.
Teach them.
This
Here.
is-
Go with this wire. Put a wire and let's see if it goes. Here. You have the wire there already.
But
Go.
if you use a second wire, the tip of this wire is gone.
Okay. Fine.
Okay.
Then fine. Then go with the
Prismatic
guide.
sector
Yeah.
and all these things. I don't
So,
even know.
yeah.
It's because you need to be on the fielder wire then.
So the options here are, as you are doing, one is to increase the support by using a buddy wire. You're trying to straighten the artery a little
Yeah.
bit so that the stent
Yeah.
goes. I think the next choice would be to use a guide extension
Yep.
catheter.
That's it. We are ready with that. Yeah.
Sir, in such calcified, angulated, and distal lesions, if rather than mini crash, decay crash will be better option, sir. What do you feel? Sir?
No, I think that probably doesn't matter. Most of our cases are with the atherectomies. Good. Okay. Now we have the guide extension catheter. Which one we have?
7.
7. Yeah. So we have a Godzilla here today. So good Godzilla guideliner. There are a few others companies are making them. So they are any one of them good. You need extension. I can tell you these extension catheter are one of the for adjunct technology. They are the biggest
Absolutely.
discovery for us, right? I mean, these kind of cases
Exactly.
we used to struggle. Somebody asked me that besides the main devices, what is the other adjunct technology which made our life different? I would say this guide extension catheters.
Cannot agree with you more, sir.
Yeah.
Absolutely. So one of the this Guide Plus is the guide extension catheter that we have now. Guide Plus, again, we have found it to be
Give me a balloon.
really very
The 3 over
trackable.
12 balloon.
It tracks nearly like a balloon on the wire, and you can take it distally, and it comes in 6 and 7. So I think that again is a very good addition to the guide extension catheters that we have.
Yeah, they showed actually one case with the Guide Plus in the India Live. I
Right.
was it from Nagpur or the one
Nice.
case they
So
did show?
I think so. Yeah, so we did a case from HN Reliance, me and Dr. Ajit
Yeah.
Menon. I think that
Yeah.
we used the
Yeah,
Guide
exactly.
Plus.
That's the one. Yep, absolutely.
I think this is nice step, sir. You have shown that second wire taken out before putting guide villa.
Yeah.
So this is very necessary.
Yeah. So now you have to go to balloon further, then only this will go. Otherwise, it's going to be a more difficult. So clearly, Guide Plus is not available in here, but in India, everything is coming back. I'm in USA. We actually now got the Opian balloon also approved just 2 months ago.
Go negative with the syringe.
Fantastic. Okay.
Yeah. And that actually double the cost of the Wolverine. Wolverine is about 650, 700, and the open balloon is 1250. And
Okay.
as I angiosculpt and Scoreflex are about about 500, 550 to 575.
Okay.
But it's at 1200. The biggest problem for us is I told them that from our point of view in our lab, since who does so many atherectomy, open balloon is very little role. Reason is you spend 1200, there is no separate reimbursement. In America, there is a separate reimbursement for atherectomy. So
Okay.
it's not that, and if you're good at it, so I said that's what we are going to use. Why will you use an open balloon? So we have a separate reimbursement for IVL, separate
Okay.
reimbursement for
Here,
all
go
three
here.
atherectomy techniques: laser, orbital, and rota. So therefore,
Go down.
if you are using an adjunct technique, if you think that other your high pressure balloon may be a rare case, you want to use
Right.
it because you cannot do the atherectomy, patient's hypotensive or some is
the
different,
stent.
but otherwise we'll use atherectomy. Why would you
Correct. Absolutely.
increase the price of the device? Because until they come with a separate code and separate reimbursement. If they do, then
Correct.
it's reasonable. But otherwise, we tried a couple of cases. Of course, we had done few in India. But here is
Right.
a lot of things in America is done. What is the basically the approval by the CMS? So once the device get
Okay.
approved, so
Okay.
same thing, classical mitral clip from
Right.
2014 approved by FDA. Didn't take off till 2016 end because CMS did not approve it.
Right.
Now
Right.
once they start their DRG and code, of course, all of a sudden mitral clip volume in the country from 200 became 400 per month. So it's a
Right.
because all the insurance, even if the good device, their use is guided by or dictated, I would say, in America quite a bit by the reimbursement scheme, because you cannot bill to the patient. Many times used to be in the past when I had the drug coated, DES initially were not approved. Patients said that, we can pay out of the pocket, but cannot.
Okay.
You cannot
Okay.
bill the patient in America. You cannot bill. That's the
Okay.
problem.
Okay. So now you see, you're finding it difficult. There was initially, Dr. Kinney showed up the beautiful inch worm technique to get the guide extension inside,
Yeah.
anchoring on the balloon and then, inching it down.
The other thing is we go shorter stent.
No, you need to go back again with the
I
balloon.
think, yeah.
With guideline a little further. That's it. Take it
No,
out.
we did.
Take it out. No,
Guideline is
we'll go
not
further.
going
No, it will
further.
go. It will go now. Yeah, take
It
this
may
out.
not go
Yeah,
further.
get the balloon.
Because-
We tried. We
Yeah.
tried.
Yeah, no, take this out. Take this out. Take the other wire out. You don't need that wire now.
Now, if you want to recross later on,
Okay.
leave it. It's not in the Godzilla.
So
So here, I
So-
think the stent will cross only if your guide extension goes beyond
beyond,
the
absolutely.
beyond. That's number
Yeah.
one. Or
Yeah.
you'll have to use a shorter stents.
Yeah, that's it. Both. So want to shorter 3/12 first? What do you want to do? Or 18? Anyway, let's go this. Let's try this first. If not, I go to second.
tried.
Yeah, no, go
It's
again
not
once. I'll tell you now. Connect.
We tried all that. Don't connect. I
Okay.
teach them. They're on the wrong things. You teach them.
Good. Just hold on.
Wrong
Which balloon is this now?
Wrong balloon you gave us.
Huh? Okay, fine. 1 second. That's fine. 1 second. Good. Just 1 second. Get a 3 balloon again. 1 second. Go fluoro. Just 1 second. Okay. Keep advancing.
No, it does not. We were not watching when
Yeah,
we
I
did
know.
this before.
Okay, just 1 second. 1 second. Yeah. Okay. Ready?
Not yet. Okay.
Okay.
So what Dr. Sharma is teaching us is the inchworm technique. You just inflate the balloon, and as you deflate,
Yeah.
the
Get the
guide
balloon further.
extension, moves forward.
Yeah.
But it's
Good. Just hold it there. Have you gone beyond or no?
Probably not.
No.
Take a cine. Huh? I
Probably-
think
We have not
Probably
gone
not.
beyond. We have
1
not gone
second.
beyond.
Huh?
no, you've not
There's,
gone
Okay.
to
beyond.
me, there's a calcific nodule
Yeah,
that we
go a little
cannot,
more here.
take
Just
care
1 second,
at
one
that
more.
level.
Your wire is okay. Go with the balloon a little more.
Then you're going to normal, almost normal
No,
looking
no, no, that's
vessel.
okay. Just 1 second. Yeah, no, don't
No.
go there. Yeah, half.
What's
Yeah,
the,
that's
no.
it.
Yeah,
Half,
maybe
half,
at
yeah.
low atmospheric pressures. Yeah.
Yeah. Okay. So now advance. Okay. Yep. Okay. Let's take out. Yeah. So now you want to try once again or the stent? That's one. Second is do you want to try the different stent, which is synergy or so, which will have better trackability? Yeah, we don't carry the
This,
Onyx, but
no,
Onyx
that's
could
not
be.
the thing.
Check.
This stent is probably destroyed anyway. We've gone four,
Yeah.
5 times now.
So you want to go to synergy?
I think we go 23, right?
No,
Yeah.
the stent
Again,
23.
The
Okay.
problem
Yeah,
you'll
when
end
you-
up putting more stent. Again, you'll have to put a proximal stent.
Yep. Yeah.
You want to try
Yeah,
it?
the stent. Yeah. Let's go
It's
the
not,
stent.
we went with that. The
Okay.
thing is.
Huh. Okay. So
Give it to me.
So
okay.
another
Try
point
the
here
new
to
one.
note
Yeah.
is that so when you retrieve a
Yeah,
stent,
the new. Yeah.
which has failed to cross, it is always a good idea to inspect the
Crimp.
stent
Beautiful.
before you
Yep.
inspect, you get it back again into the coronaries, because sometimes the stent gets deformed and you pull up a few things there, and this could actually, and when you go in, you could actually perforate the artery when you deploy it.
Beautiful point. Then we did this so far looking good. Good. Did the job. Okay, good. That's all we need. Yeah, see, we went a little bit further. So as you said, the tip of the Godzilla, as Jaspal, you said,
it's
we
just-
had to beyond. Yeah, so take it
Yes,
out
it's
now.
just
No, it will
beyond.
not.
What do you
it's
want?
just
Take it.
beyond.
As you're inflating, I'll have to take it out. The stent
Yeah.
will come back. Okay, go up.
Huh?
Again, we remember to get
You
the
don't
guide
want
extension
come
catheter out before we
out.
inflate the stent.
Yeah,
Because
course.
yeah,
Okay.
Good.
Not from
people
now,
have
yeah.
shown cases where they forgot to get the guide extension out. So
Good.
I know what you're doing.
Yep.
Okay, go up.
Go up. Yep. Yeah. So key was you needed to beyond that crushed stent. As long as we went to the
Right.
ostium, and you can see here still.
Keep
So we kept the part of the balloon in the guide extension and tried to push it as much as possible. And of
So
course,
the
we'll
ostium
require.
of the OM is
Yeah.
not expanded. You
Yeah.
see it?
So we go
yeah,
to
it
high
is.
pressure
Ostium
now.
is,
If not, then we can get the IVL. This is the type of case now that you do a rotatripsy.
right.
Take a picture.
Yep. Okay. So this was a tough case. So whatever require you to do, good. I think looks okay. Now you can go to very high pressure 308 or 12. You already have 30 balloon. We can do it now. Before you start doing the kissing balloon. See that nice bifurcation, nice crush. You can see the jumbled up little material of the stent
Right,
into the
right.
distal circ. So we know it's fully covered. And now we just go with we can remove the guide liner. We don't need that.
Yeah.
Or Godzilla. Yeah.
Can you? I think
Good.
you could just release the tension also on the
did.
guiding catheter.
She did.
Seems
Yeah,
to
she
be
did now.
hitting the roof. Yeah.
Yeah.
So
He just
we have
did.
to take care. This was a real complex case. First of all, circumflex, then tortuosity, and then calcium extending into both
Go
the
to the
vessels.
trio balloon. Yep. Yep. Absolutely. All complexity.
Yes.
Yeah. Go. Okay. So now you want to recross? Let's open this and then recross.
No, don't give me all new balloons.
No, for
That's not
recrossing, yes. But you want to open that OM1 a little more?
I think this has been used multiple
Okay.
times.
Get a 2.4 compliant balloon. Let's go to the compliant for the distal circ first. Because it will be a tough one to go. 2012?
212, yeah.
Yep.
May not even go there.
You probably need a new wire. It has been.
I think the wire is okay. It's just calcium tortuosity.
Many delegates are interested.
Yes.
Many delegates are interested to see that distal leffment on imaging, sir. They want to see.
No. Oh, yeah. We're going to do the imaging. Yeah, definitely. The imaging will be done. Yep. Good. So So let's open this, and
That's
then
your
we have the
cross.
2 balloon there. Yep. So wire, now the fielder wire has gone back into the distal
What
circumflex.
is this?
This is 3O balloon. Yep. Which we had before.
I may not go. You have the IVUS ready, flush it. At least we can do. Yeah. Never done this long cases.
Good.
So now the next plan is to the cross into
I told you,
the
do
circ,
not.
the
These
primary
balloons
circ.
are useless.
Yeah. Yeah. So we are ready with that. 1 second. 1 second. You keep it inside. 1 second. We are decreasing the profile. Fluoro. 1 second. I'm decreasing the
Get a
profile.
new 3 or 12 high pressure balloon. Don't give me the Neo. You have the other one. What is that? 15?
Good. Just hold it. Hold it. Hold it. Let me open, and then we'll go further. We are in the stand. No matter what you do, is always a moderate pressure. Now go a little further. Good. I'm going up. 1 second. Good. Okay, going up now. Here we can go to high pressure. Yeah. Okay. 24 fluoro. It's still
Do you see
undilated.
that? Yeah.
Yeah, and
That nodule was there from the beginning, which was
yes,
avoiding
Yeah.
everything.
yes.
Okay. Good. So let's cross the distal with a 2O balloon and dilate here
Go
more.
up here, yeah. I think we should leave this alone for now.
Yeah,
We're not
that's
going
fine.
back with IVL and all that.
Yeah. Okay.
Leave it.
Now let's
Yeah,
see
I
the
think,
lumen.
you know,
No, but if the lumen
think
is
the
about
lumen-
about 4 plus
exactly.
millimeter,
Yeah, good.
4 or so, then
should
we'll be
be good.
okay. Yeah. Good.
Perfect. Absolutely.
Oh.
I think rather than
Oh, hold on. 2O.
chasing it, let us
Huh?
see the
Yeah.
lumen on imaging and then
Yeah.
take a decision.
That's right. Yeah.
Okay, good.
Good.
Now what,
Yeah.
give that 2O balloon.
Right there. And after that, we can show the IVUS, and then we will go on our rest of the case discussion and presentations of the rotablation complications and so. But first thing is, we are going to cross the distal circ with a 2O balloon right now, and then do a kissing balloon, and then do the imaging, and then we go further for our work. And of course, tell both ostial OM as well as the left main that how the left main is.
Mm.
Went in. Good. Go a little further. Yeah, good.
Good. Okay,
Okay.
go up.
Yeah.
Go high because it's a 2O balloon.
Yeah.
12, 14.
I'm going to.
I think
Yeah, it's a 2O balloon.
allow because
Yeah.
Down. Okay. I do
Charge
IVL.
Ostium, you have to open a little more here. Pull back this.
Okay,
Yeah.
go.
Go 20 atmosphere.
Hold on.
IVUS is ready, cleaned.
Plug.
Good. Good. Okay. Negative.
Down.
You can take both of them out. Show us the picture, IVUS, and boom.
Okay, ready?
Good. Okay. Good. Good. Let's show the IVUS.
Okay.
Yep. And the lumen, I would say my cutoff will be 4. If the ostial OM, the lumen MSA is less than 4, then we'll combine with IVL. Otherwise,
Okay.
more than 4, we'll leave it. We know that it will be less, but as long as the cutoff will be 4. Yeah. Go. So we are
Okay.
going to go with the in OM now first, with left main to OM. People want to see this is in the left main, and so.
What if the IVUS does not cross?
No, IVUS will cross now. IVUS
Let's hope
definitely
it
will
does.
cross now. Yeah. Now it will.
Again, here the option that you do is OPN and C. The
Yeah.
other option from IVL would be
Could
OPN
be.
and C
Yeah,
here.
that is correct.
Possibly,
Yeah, this is the type of case. You are right. Absolutely.
Oh,
Your wire came out. Yeah.
we pulled it out. Everything is had it
Pull
enough.
back the IVUS.
Everything had enough today.
Wire is destroyed. You want to take it out? Go
Let
on
me
the.
take it out and go on the fielder, put
Yeah.
the fielder on the other side.
Yeah.
It's time for everything to stop.
Mhm. Good. Yeah. Flush. Good. Okay. Let's see the main important. So many important and teaching points, learning points, teaching points in this particular case, and now we are ready for the. I call it as a grand finale, which will
Yes.
put everything in perspective. Where we are, whatever we did, and we did more or less. Good. Beautiful.
Told you, IVUS may not cross.
Huh? You know what I'll do in this particular case? You have the guideliner. Clean it up quickly. Yeah. Use that guideliner. You know what is happening at the angle?
Mhm.
Because of the short monorail. Take this out. Short monorail. It is just buckling. So we just bring
Buckling
the
there. So,
guideliner to the ostium, and it will go in 1 minute. Okay.
so I think, this case is,
No, other thing
using
is
all your
the IVUS,
expertise.
IVUS
Yeah.
catheter could be destroyed also by now.
Yeah.
So far, no, we saw the images was good
No,
before we went in.
the tip
Okay,
keeps.
good. Let's go into the
pushing
tip.
back.
If it goes, yeah, put this one. So you
You
need
have a 7F,
your Godzilla just at the ostial circ.
right?
May
And
not.
is this
Yeah.
a 7F guide extension catheter?
It's 7, yeah. It was,
Okay.
they put it 7, would not go.
No, I
Okay,
think
then
you,
you need the balloon.
need it. You need balloon. You have to go back again.
Okay, let's get the balloon. So, okay. So we have our balloon 3 or any balloon we have?
12.
3 or 12, yeah, right here. I can tell you, I've never been that curious to see the imaging, but in this particular case, my curiosity is very high. I'm sure many of people will be thinking that way too.
Yeah.
Because we have brought a stent just up to 2 millimeter inside the circumflex.
You have,
So you have
such
to go to negative.
difficulties,
You have to go
I
to
understand.
negative.
Yeah, but then you do negative with the syringe.
Yeah,
I don't know what you teach them.
but that's all you need.
Okay,
You
go
don't
up
need
here.
further. Yeah. Go up. Good. That's all you need. That's it. Okay. Deflate. Good. Good.
Now we are at the
Yeah, take it
ostium
up.
of that stent,
Yeah.
so we have to be very careful not to extend the Godzilla and push because it can cause LSD. If you
Right.
need, we have to bring the balloon back and then do the suction on the balloon. Yeah. So we stop there and let's see if the IVUS will go now.
Yeah. Because earlier that angle was the trouble. We saw that separation. If you
Yeah.
go.
It
So
was
see
going
this now.
into the LED.
Yeah. Yeah, exactly. It was going into the LED and here. See, this is the one.
Okay.
Just one
fine,
second.
fine.
Yeah. See that?
Flushed
See?
again.
So that one was earlier. So it goes into
Right.
that LED because of the very short monorail.
Right.
Yeah. Good.
So with guide extension, we'll be preventing that, so that.
That is it. That's what I felt that you need take away that equation, adverse
Yes.
factor into this and boom, went in. Good. Guide extension
Yeah.
back.
Okay.
Change the IVUS to the screen.
Okay. Start
IVUS.
Kiski.
Okay, thank you.
Let's
Okay,
show
I
the
was
IVUS.
onto the main screen now.
Yeah.
Yeah.
Start pullback. It's a native. Super
Yes.
pistol.
Yes.
Yeah, it's coming. Yeah, some one quadrant custom. Yeah, this is a distal edge. Yeah, looks good. Expanded.
Good.
It's coming. Yeah, looks expanded. Yeah, here's a kind of elliptical shape.
Yeah,
Maybe
this is a
will
lumen.
awesome. Yeah, I can check the area later. Yeah,
Yeah,
the
check
box
the area.
circle is well expanded.
Nicely crushed.
Yeah.
Yeah.
You
Good.
could see the crushed stent.
Yeah.
Yeah.
Yep.
And
Well
then
expanded.
the ostial circ,
And the left main.
left main.
Yeah,
So
Guide-
the
the guide
proximal
should be
looks
out.
good.
Yep.
Yeah, it's
Now
good.
come to the native. The bifurcation.
Yeah, left main is fine. There is no disease,
Left main.
no
Okay.
narrowing. Yeah.
I will stop.
Okay.
Okay.
Give us the CSA
Of
of
the
that ostial
OM.
OM.
Sure.
Yeah.
So this is the distal edge. Come to proximal.
So
Like
remember,
Like that.
yeah,
Okay. No, but is that the one?
this is the one.
Yeah,
Yeah.
this is the bifurcation. Yeah, here.
Okay.
Still look at the calcium arc.
Yeah.
Unbelievable.
Yeah, it's
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 still-
You
360.
probably needed a
360
1.5.
outside
Yeah.
behind a stand. Yeah.
Just
1
4.
second.
I think we'll leave it based on everything. Take a last.
Yeah, so I think it is a little more than what is guys. It's
Yeah.
four.
Yeah. He's
Yeah.
your measurement, my friend.
But
Yeah.
Yeah.
one second.
Yeah.
Good. Let's
You're
take one
like a-
picture.
Yeah, I
Other
think-
view, we're done. We'll go up. Yeah.
So
Because
I
we
think
wanna
it's
Take
well
the wire out.
expanded
Take
and
the wire
this
out.
is
Yep.
perfectly acceptable.
Good.
You know,
Yeah.
with
Yeah,
that calcium that we have,
Ready?
this is perfectly acceptable.
Ready? Okay.
Beautiful.
Beautiful.
Good. All right. So with that note, we complete our case from here. Good. You want to talk about rest of it? We done no
No,
more
Yeah, air
picture. No more
karma
picture.
of
Yeah.
1.7.
Yeah.
Air karma of 1.7. Total fluoro time of 33 minutes. Contrast of 130 cc.
So, and I think with the complexity of the case, an absolutely wonderful case done in less than an hour. It was, I think
No.
there was challenges at every step, and a lot
Yes.
of takeaways and learnings, for everybody who has watched it.
Beautiful. And thank you for
Absolutely.
both our moderator and faculty to give a lot of input, making a very lively discussion. We loved it. And you can start your presentation. I'll join you in about 5 minutes. Going to my room.
Perfect,
Thank
sir.
you very much.
I'll do that, sir. Thank you very much, sir. It was a wonderful
Bye-bye.
demonstration.
Thank you.